Good morning, everyone. My name is Horst Neuhaus from the Evangelische Krankenhaus in Düsseldorf, and it's a great pleasure for me to participate in this outstanding virtual conference. And it's wonderful that I can share this session together with my friend Amit Maideo from the Baloda Institute of Digestive Science in Mumbai, India. Good morning, Amit.
Good morning, Horst. Hi. Can you hear me?
Yes, of course.
Oh, well, good morning, and good morning to all our speakers and our participants. Yes, Horst, I think you can go ahead and introduce the speakers.
Yes, then I have to introduce myself.
Oh, okay.
I give the first lecture.
Oh, you're giving the first lecture. Yes. So it's my tremendous privilege to introduce to you Professor Horst Neuhaus, who is one of the most leading endoscopists of the world. And he has done exemplary work, not only in the field of interventional ERCP, but in all aspects of interventional endoscopy. And so today he's going to talk to us today on a very special field, that is cholangiocarcinoma, the latest trends in cholangiocarcinoma. And he's in charge of the Evangelist Krankenhaus at Düsseldorf in Germany. So Horst, it's a great pleasure for all of us to listen to you today.
Thank you. No, it's a great pleasure for me to participate in this outstanding virtual conference and to talk about latest trends in cholangioscopy. So these are my disclosures for Tokyo Live 2020. And firstly, I would like to mention different methods for cholangioscopy. So for many years, we had only the option to use the mother and baby scope system, which is still available, in particular in Japan, but it can be only used with the Olympus Lucera system. It's quite fragile and it's rarely used in Western countries. The other alternative is direct per-oral cholangioscopy with the advantage that we can use pediatric gastroscopes for entering the common bile duct with the option to use any kind of accessories which can be passed through the 2-millimeter working channel, and we have even NBI. The challenge is to overcome the angle between the duodenum and the common bile duct. This can be facilitated by using guide wires and anchoring balloons, as shown here in the left hepatic duct, and then by pushing and pulling, we can advance the scope deeper into the CBD. However, at one stage, we usually have to remove the balloon for interventions, for example, for taking biopsies, and then it's quite difficult to keep the position of the scope, depending on the angle to the papilla. So this technique can be improved by using a multi-bending ultra-slim Kolendoscope, which was developed by Olympus, which has two bending sections, and this facilitates to pass the papilla to overcome the angle into the common bile duct. It has a 2.2-millimeter working channel, and this, of course, an enormous advantage compared to other type of cholangoscopes because we can use regular accessories, and in addition, a small channel for irrigation or CO2 insufflation. So we recently participated in a randomized controlled trial to compare multi-bending versus conventional ultra-slim endoscopes for DPOX, 92 patients together with a group of Dr. Moon in Seoul. And the results indicated a significant advantage for the multi-bending scope. Freehand biliary insertion succeeded in 89% compared to 30%, and it was also faster. And the technical success rate was 93%, though this was not significant difference from the conventional scope, and there were no difference in terms of adverse events. However, so far the scope has not been commercialized. So DPOX has advantages, but it's a longer learning curve for using it, in particular for difficult interventions. And this is obviously much easier with a single operator kolendoscope developed by Boston Scientific, the spyglass technology, which can be very quickly set up with a fully integrated system. Just plug in the cable to the controller, and we have a CMOS video technology with an excellent resolution, 2 LEDs, 4-way deflection as shown here, excellent maneuverability, and a dedicated irrigation and aspiration connection. So we can flush and we can also suck to decompress the duct to minimize the risk of cholangitis. So what are the indications for cholangioskopy? Mainly to evaluate indeterminate ductal lesions, delineation of intraductal lesion margins, in particular before surgery, treatment of difficult ductal stones, and we have a couple of other less frequent indications. So several uncontrolled trials were reported for evaluation of indeterminate biliary lesions, and this is a recent study from Almadi in 289 patients, a prospective multicenter registry, and the sensitivity of spyglass in terms of visual impression, 87%, biopsies for malignant lesions, 75%, so substantially higher compared to all studies on brush cytology or biopsies done under fluoroscopic control. Specificity 71%, 100% for biopsies, so no false positive results. PPV 66%, NPV 77%, overall accuracy 77%. So very promising data, but these are uncontrolled series. So we recently did a study together with the center in Hyderabad in Hong Kong to evaluate indeterminate biliary lesions within a randomized controlled trial to compare ERCP-guided brush cytology with spyglass-guided biopsies. In 29 patients spyglass, 32 ERCP alone, and the sensitivity of visualization was significantly higher for spyglass compared to ERCP, 96 versus 74%, and also the overall accuracy. The sensitivity of spyglass biopsies, 68%, superior to brush cytology, which was quite disappointing in this series on 23%. So very promising data. I would like to show you an example, a patient with a hilar suspicion of a hilar cholangiocarcinoma, so ERCP suspicion of type 3A. And now it's very important for the surgeon how far the left liver lobe is infiltrated. So we inject contrast through the spy scope to avoid unnecessary injection of contrast to minimize the risk of cholangitis. And now we target the left hepatic duct. So this is guide wire cannulation under direct vision to the left hepatic duct. We inject some contrast, so we see the stricture here close to the hepatic confluence. And now for the hepatic surgeon, it's very important how far is the cholangiocarcinoma invading the left liver lobe. So we are here in segment 2. This was normal epithelium, and now we cannulate segment 3 with a guide wire, and this is the proximal edge of the tumor. Here we see the irregular surface, typical vessels, irregular vessels. Now the guide wire is in segment 3, And now we have a very precise information. So this is a proximal tumor margin, and here is the junction between segment 2 and 3, and in between there is just 1 centimeter of regular tissue. And this is a very important information for the surgeon to decide if this is still a candidate for extended right hemipatectomy. And this technique, mapping of biliopancreatic neoplasia for determination of resection margin, was studied in 118 patients, published by Tyberg. Most of the patients had cholangiocarcinoma, some IPNN, and the surgical plan was changed in 1/3 of the patient based on the informations on direct visualization of the biliary system, either with avoidance of surgery, less or more extensive surgery, and a high correlation between endoscopic and surgical histology. So a very important impact on diagnosis. So what is the role of cholangioskopy for therapeutic interventions? Of course, common bile duct stones which cannot be removed with standard techniques, including mechanical lithotripsy, impacted stones, and intrahepatic stones. This problem cannot be solved with standard endoscopic techniques and ERCP. So here we see on MRCP complete blockage of the left hepatic duct with proximal dilatation due to stones, but this could be also associated with cholangiocarcinoma. And this is a video sequence of the ERCP, followed with spyglass cholangoscopy. The guide wire is in segment 2, so it was difficult to pass the wire because of duct obstruction due to the stones. And now we advance the spy scope over the wire into the left hepatic duct and then into the radicals. And we see here small stones, and with flushing, we increase the pressure upstream of the stones so they come then forward towards the hepatic confluence. And then we remove the wire, and impacted stones, stones which cannot be removed with flushing, have to be disintegrated here with the EHL. And you can appreciate that we can nicely target stones due to the excellent maneuverability here in segment 2 and 3. And with flushing, we can finally remove these small fragments. So this technique, therapy of difficult bile duct stones, was studied in a prospective multi-center registry in 17 Asian centers, published by Maideo, 156 patients, and in whom conventional techniques had failed in 80%, stones were impacted in 65%, and ductal clearance was achieved in a single session in 80%. This is also the advantage compared to extracorporeal shockwave lithotripsy, that we can achieve a complete stone clearance usually in 1 session. And just published in CGH, single operator guided laser lithotripsy versus large balloon sphincteroplasty, single center randomized controlled trial from Orlando. 66 patients were enrolled with stones that exceed the diameter of the extrahepatic bile duct, and the results indicated a high success rate for spyglass, 94% versus 73% with large balloon sphincteroplasty. No significant difference in adverse events and overall treatment costs. So very effective even in patients with stones which may be also treatable with mechanical lithotripsy. A couple of further indications: percutaneous transhepatic interventions, radiation-free removal of ductal stones, removal of migrated endoprothesis of foreign bodies under direct vision, and resection or ablation of intraductal tumors. So Spyglass Discover has recently been introduced. This is the device for the percutaneous route with a much shorter length of the tube, which facilitates manipulation. And here is an example in a patient with Roux and Y anatomy. We couldn't approach the papilla, large common bile duct stone, so we did percutaneous drainage. We have a stable tract after 7 days of just only 12 French. We removed the tube, and now we can introduce spyglass directly. Under direct vision, we have the flushing capability, maneuverability. So we insert it through the sinus tract, through the tract in the liver, and then approaching the stone here. And we now rotate and enter the left hepatic duct from the right side, showing the high flexibility and maneuverability. So with this technology, we can access all biliary radicals. So here we in segment 2, stone is here in the common bile duct, and we can even retroflect, as you can see here in the arterial lobe of the right liver. There are no additional stones, and therefore we continue this procedure with lithotripsy of the large common bile duct stones, so insertion of the EHL probe. And as you can imagine, under direct visualization and continuous irrigation, we have a very effective technique for disintegration into small particles, and then we push the small fragments through the papilla to achieve complete bile duct clearance. And another option is radiation-free removal of bile duct stones. Here in a pregnant patient, we use the ERCP single-use duodenoscope for cannulation of the common bile duct. We aspirate bile to assure that we achieve the deep bile duct cannulation, followed by sphincterotomy. So this pregnant patient, US, showed a solitary common bile duct stone. We leave the guide wire in place, insert the spyscope over the wire, which is an alternative to freehand cannulation. So we wanted to minimize, of course, the risk of pancreatitis. And now we are in the common bile duct, and now we use the spy basket, which allows to capture the stone under direct vision. And we could easily remove now the stone, and radiation exposure could be completely avoided. So I would like to conclude. Single operator cholangioskopy is the technology of choice for cholangioskopy because of its easy application for a variety of indications and the well-studied efficacy and safety. It seems to be superior to ERCP alone for evaluation of indeterminate ductal lesions. It's effective after selected ERCP failures, in particular for difficult biliary stones, and allows complex radiation-free interventions. So congratulations to your conference in Tokyo, and you are also kindly invited to attend our virtual Düsseldorf International Endoscopy Symposium in February next year. Thank you very much for your kind attention.
So thank you, Horst. It was a really wonderful and a very comprehensive lecture on the latest trends in cholangioscopy. So before we move on to the next speaker, and I asked you to introduce Dr. Jack Davier, Horst, I just want to ask you a few quick questions. First is, you showed the excellent results with the sensitivity and specificity of the use of cholangioscopy for tissue diagnosis inside the bile duct. And the gross difference between the diagnosis which you could achieve with a breast cytology as against a cholangioscopy guided biopsy. So do you think that in the future, as a routine, we should use this as a primary modality for taking a tissue? what's the need of trying to do a breast cytology, and then if you get it negative, and then go ahead with a cholangioskopy? So if a cholangioskopy is available in your unit, and if you want a tissue diagnosis, should we use that as a primary modality for a tissue diagnosis? What is your take on it?
Yes, I think so, because firstly, we have less radiation exposure, and as we do as endoscopists also in the GI tract, we would like to take biopsies under direct vision. We know exactly the most suspicious lesion and can take several biopsies from the same spot. And if the sensitivity is really higher, let's say 15 to 20%, then we can also refer to cost-effective analysis, which were published by Dr. Desprez, showing that finally the overall costs are less with primary approach with cholangioskopy, because otherwise in false negative you have to repeat ERCP, and this increases the cost.
And do you think that we need to take any special precautions when you do a cholangioscopy or a spyglass for a hilar block? Don't you think that it can add to the chance of cholangitis, especially if it is a type 3 block?
Absolutely. This is, I think, very important to flush as little as possible to minimize and increase pressure upstream of strictures. And as I've shown also in the video, we don't fill with contrast. We have all the information about MRCP before we starting with cholangioscopy, and then we just target the area of interest and cannulate with a guide wire, take biopsies. So we inject very little contrast and saline, only just to have a good vision, not to be continuously on the pump irrigation.
Okay, so even if we do use it, then we have to make sure that we achieve a good drainage at the end of the procedure to prevent the cholangitis. Yes. Yeah. Okay. And what is your take on the treatment of Mirizi syndrome? Do you treat it with cholangioscopy and EHL or laser, or you still feel it could be left for the surgeon?
No, we always try to solve the problem endoscopically, because all biliary surgeons do agree that this is a very big challenge for surgeons to manage Mirizi. And when we can do it with cholangioscopy and guided laser or EHL lithotripsy, then I think it's a method of choice.
Okay, thank you very much, Horst. I think it was a fantastic presentation and very eye-opening. You presented a lot of good data. And I would request you to please introduce our next speaker, our friend, Dr. Jacques Davier.